Hello, everyone. Welcome to our webinar. We will be reviewing perioperative management of the lactating patient in the ambulatory surgical setting, led by Dr. Kara Barnett. I am Elizabeth Reith, an Associate Professor of Anesthesiology at Memorial Sloan Kettering Cancer Center in New York, New York. I will be moderating this webinar. For those of you who are not SAMBA members, please consider joining the society, as it offers many benefits to members. Please visit our website, www.sambahq.org, to see the benefits of membership. A few quick housekeeping notes before we get to today's presentation. Please note that this webinar is listen-only mode. In the upper right side of your computer screen, you will see a Go to Webinar control panel. Through this control panel, attendees will have the ability to contact our staff via the question box. We will have time for Q&A at the end of the presentation, but please submit your questions throughout so that we can prepare to answer. At this time, I would like to introduce tonight's speaker. As you already know, our speaker is Dr. Kara M. Barnett. Dr. Barnett is an assistant attending anesthesiologist and director of anesthesia services at Memorial Sloan Kettering Cancer Center Monmouth Regional Site in New Jersey. She has been with MSK since 2009 and was active in planning and opening MSK's only freestanding outpatient surgical center in New Jersey in January 2017. At MSK Monmouth, Dr. Barnett solely cares for surgical, GI, and interventional radiology cancer patients. One of her passions is caring for the perioperative lactating patient, and she has published and presented on this topic. Over to you, Dr. Barnett.
Thank you, Dr. Reith. Hi, good evening, everyone. Thank you for joining. I hope you're all safe and healthy. Tonight, we are going to discuss my passion, which is how to take excellent care of the lactating or breastfeeding perioperative patient. I wanted to take a moment and tell you why this is so important and why I applaud you for joining me tonight. I asked some mothers about their experiences with anesthesia and breastfeeding. One mother told me she had surgery recently while breastfeeding her 5-month-old, and not one person in the hospital told her the same piece of information. She had stress and frustration as she unhappily and needlessly threw out breast milk. Same for the mother of an exclusively breastfed 9-week-old preemie who had an emergency D&C for retained placenta, and she was told to pump and dump for 24 hours. She reports that it was so hard and painful to watch her hard-earned breast milk go down the drain. Another misinformed mother told me she pumped and dumped after a thyroidectomy and reports it was like pulling teeth procuring a pump in the PACU because she did not think to bring hers with her. A mother told me she had major surgery with anesthesia recently while she was nursing her 2.5-year-old. When she asked her surgeon when it would be safe to nurse afterwards due to the anesthesia, she said, and I quote, "Well, it would be a long procedure, so maybe she will finally wean." On the day of surgery, she asked several staff, including her anesthesiologist, when it would be safe again, and she got different answers, ranging from 2 hours until after waking the next day. This left the mother very confused. Another mother told me about an experience that she had with an ER that I think is relevant. She was given Keppra and says, and I quote, that I couldn't continue to breastfeed my then 8-week-old after nursing my oldest to 28 months for what I thought would be forever. And it was the hardest part of the scariest moment of my life. The ER probably didn't give their advice a second thought, but a few physicians taking my concerns seriously really changed my life. She had contacted a neurologist who was able to tell her it was safe to breastfeed. This changed her life. So let's get started and see what lives we can change. Okay, so I have no disclosures. So tonight I will cover everything an anesthesiologist should know about caring for lactating patients who come for surgery, emphasizing ambulatory surgery for this discussion, but I'll also include a bit about non-ambulatory surgery. I'll try to make this a little more interesting by telling you our story of how we developed a supportive program for lactating patients at MSK, covering preoperative, intraoperative, and postoperative care. We'll discuss perioperative medication compatibility, and staff and patient education and relative resources available to both. We'll start and conclude with a case of a breastfeeding patient with bladder cancer who was scheduled for cystoscopy and transurethral resection of a bladder tumor at my outpatient regional surgical center. If there's anything at all that you can take away from my talk today, I'm hoping it is that anesthesia is almost always compatible with breastfeeding, and it's unlikely you'd have to tell a mom to pump and dump for 24 hours. I wanted to introduce this case to you now so you can start to think about what you would do if this were your patient at your surgical center. And as this presentation continues, your ideas may change. So we had our first lactating patient at my outpatient regional surgical center. She was a 32-year-old woman with bladder cancer. She was scheduled for a cystoscopy and TURBT, and she was identified as breastfeeding a 5-week-old infant. We typically do a general anesthetic with LMA for our patients that are getting TURBTs, and we also typically give a belladonna and opium suppository in the operating room while they're asleep, and then give as needed pyridium and oxybutynin in the PACU. So in 2014, while I was still at our main hospital in Manhattan, we recognized a deficiency in our care of our lactating patients presenting for surgery or procedures that required anesthesia. So who is we? It was me, another anesthesiologist, a few PACU and pre-surgical nurses, and one who was working as a private practice lactation consultant outside of MSK. We saw that these patients were in the middle of a tsunami of misinformation. At that time, our department had about 40 anesthesiologists and over 100 nurse anesthetists, and there were numerous other hospital staff like office practice nurses, nurse practitioners, physician assistants, surgeons, who also had their residents and fellows, and they were all providing these lactating women their own anecdotal advice, which usually was pump and dump for a day or two. We are a cancer hospital, so in the absence of a labor and delivery department and in-house lactation consultants, there was a huge knowledge deficit. We created the multidisciplinary hospital-wide lactation task force in 2014, which consists of anesthesiologists, surgeons, perioperative nurses, dietitians, pharmacists, and IT staff. So I wanted to tell you all this story so that you understand where my information and practices that I present to you are coming from. These were created out of our main hospital experience, but we have expanded it to our regional surgical sites, including my surgical site. So first, we identified the gaps in caring for the lactating patient at our institution. We knew that our patients were presenting on a regular basis, but our population was unquantified. We had no alert system, so we usually find out that we had a lactating patient on the day of surgery when one of my anesthesia colleagues would ask what they're supposed to do. Patients were unprepared, uninformed, and misinformed, being told to pump and dump. They expected us to be able to provide them with equipment like breast pumps and bottles, but at that time we didn't have any of that equipment because we don't have a labor and delivery department at a cancer institution. There was an institutional need for more information sharing as patients were just left to figure it out. And the stress of surgery and lack of support could lead to premature weaning. So one colon surgical patient that I have a vivid memory of had a very stressful experience back in 2014 because she was told she had to pump and discard after her pre-op MRI, during her pre-op bowel prep, and after her surgery. So when I met her, I tried to do some damage control, but she was given so much misinformation. It made her desire to exclusively breastfeed her 8-week-old infant virtually impossible. Post-operatively, she was too uncomfortable to pump without assistance while on the floors, and she had nowhere to store her breast milk. So we knew that we could do better for these patients. So next, we applied for an IRB waiver, which enabled us to collect data on our lactating patients so we could quantify the number of patients that were being informally identified. So with this information, we were able to show our institution that we needed additional policies and procedures and a standard of care for the lactating perioperative patient. So when we began our data collection in August of 2014, we had an average of about 2 lactating patients per month for the whole center. Now we're closer to about 3 to 4 patients per month. And during the first 2 months of 2020, we actually had a total of 17 patients. So I think part of this increase is possibly due to better education of our staff, leading to better patient identification. But I also think it's because breastfeeding has also become increasingly more popular in our area. So I wanted to share with you all the Memorial Sloan Kettering Cancer Center experience. This is our data for the entire center. It's for inpatient and outpatient surgeries at all locations. And this is from when we started documenting our lactating patients back in August of 2014 until December of 2018. And this was actually from a poster that Dr. Reith and I presented at SAMBA last year. So 58 out of 148 patients, or just over 39%, of our breastfeeding patients were outpatients, and the average age of the babies was about 5.5 months, and it ranged from a few weeks old to a little over 4 years old. A majority of our patients, almost 84%, underwent general anesthesia. It's likely because of the types of surgeries that our lactating patients tend to get. So these are our most common surgical procedures. And again, this is for both inpatient and outpatient. Most of our cases, almost 36%, are thyroidectomies with or without neck dissections. It's also likely due to thyroid cancer being the most common endocrine malignancy, affecting 14 out of 100,000 pregnant women. The second most common is our minor soft tissue tumor at almost 20%, and then ambulatory gyne at almost 12%. So these are our components of our institutional standard of care, which is very extensive. I'm just going to discuss the highlights that I think are relevant to us as anesthesiologists, broken down by preoperative, intraoperative, and postoperative workflows. So this is our preoperative, pre-surgical testing workflow before the patient comes in for her procedures. So our nurses and nurse practitioners screen our patients of childbearing age, which to us is age 11 to 50, for lactation status. So most of this occurs in the pre-surgical clinic, but for those that are not seen in the pre-surgical clinic, like our gastroenterology patients, a nurse calls the patient with a set of questions and also screens them. Yes triggers an alert to our group and pharmacy. And before that, we had email alert triggers, and they had to actually manually email us, but now we actually have an automatic email alert go to us. Patients are given a copy of our patient education handout, which I will show you shortly. And typically one of the anesthesiologists in our group will call the patient and prepare them. And we also ask her to contact her pediatrician regarding breastfeeding post-operatively. So this is our institutional patient education handout that our group wrote and is given to all lactating patients coming in for surgery. If you want a copy, I've been able to actually Google this at home by typing in some of the keywords you see, like lactating, surgery, and with our institutional initials of MSK. It includes instructions for patients, including contacting her pediatrician, bringing all her pump and pump accessories, her cooler with ice, all that kind of stuff, and instructions of what to do in terms of breastfeeding or pumping after surgery. We also have other resources listed, though more for our Manhattan location, for patients that are from out of town who don't know where to buy additional supplies if they need them from the local stores. So as I mentioned earlier, one of the anesthesiologists from our group calls our lactating patients prior to the procedure. So during our preoperative call, we ask many of the questions that you see here. I think it would be ideal to call breastfeeding patients if you have a way to be alerted when one is coming in. But if not, some of these same questions are useful to ask when seeing the patient during the preoperative assessment on the day of surgery. So what are your breastfeeding goals, and do you wish to continue breastfeeding? So these are good questions to ask, as some breastfeeding women use surgery as a time to wean, especially for older babies, or perhaps they're going to receive chemotherapy or have an intervention, which may make it difficult to continue breastfeeding. So some of our breast patients have been told by the breast surgical team to wean before surgery because of a risk of a milk fistula. I'll mention this a few times. The age of the child is important, as younger babies have immature guts compared to older children. And as the child matures, their guts become less permeable, especially at about age 6 months. So younger babies that depend on breast milk for all or most of their nutrition may also be more affected by medication's incompatibility with lactation, especially if there is a required interruption of breastfeeding, versus an older child who may also be taking in solids and are not fully dependent on breast milk. Also note that during the first few days of life, there are large gaps between the lactocytes, increasing the likelihood of drugs in breast milk in the neonatal period. However, it may give you some assurance that in the newborn period, sleepy babies usually also don't take in a large volume of breast milk. For younger babies, I usually ask about how old the baby was at birth and if there were any health issues at birth, because that may also affect how conservative I am with my recommendations of breastfeeding resumption. I usually ask, did baby require any stays in the special care nursery or ICU? Another question that I ask, but not included here, is baby healthy and does baby have any health issues like respiratory issues? How often do you breastfeed or pump? We recommend that mom tries to follow her typical schedule on the day of surgery, but this may be more problematic for longer surgical cases. Not all mothers who breastfeed pump. Some questions like, do you have a supply of refrigerated or frozen stored milk? Will your baby take pumped breast milk from a bottle? Does your baby take formula or solid food? And do you have a pump and supplies available? Are to get a sense of what obstacles the patient may encounter in the perioperative period. Do you have a pump and supplies available? So breastfeeding patients who do not pump and are separated from their babies for longer periods of time are more likely to have issues in the perioperative period. If mom does not normally pump, it is very likely that the baby does not feed by bottle. So you may end up with a baby who refuses breast milk from the bottle. Moms who do not pump may not be proficient at pumping. If mom needs to pump and she's not very good at it, she can end up with engorgement, plugged ducts, and even mastitis. Some patients may end up introducing formula preoperatively as a backup plan, especially if she doesn't have much breast milk stored, but some do not. Will the surgical procedure affect breastfeeding or pumping? So some longer cases may put the patient more at risk for engorgement, or some cases like breast or chest surgeries may interfere with mom's ability to pump. So as with everything else in medicine, let's formulate a plan that is evidence-based so that the care team and patient can make informed decisions. Interrupting the breastfeeding relationship can cause mastitis, which can mimic a post-operative infection. So we like to use the term compatibility when discussing the safety of breastfeeding after surgery. It is a better word since it acknowledges a risk-benefit balance. So remember how I mentioned that some healthcare workers may prefer the advice of pump and discard for 24 to 48 hours after surgery, as they are saying they're erring on the side of caution. This is not evidence-based. So according to the American Academy of Pediatrics, healthcare providers should weigh the risks and benefits when prescribing medications to breastfeeding mothers. Physicians need to consider multiple factors, and what are they? First, the need of the drug by the mother. Well, our mothers need anesthesia, but you may also be able to tweak the anesthetic that is more compatible with the resumption of postoperative breastfeeding. Perhaps you could use a regional anesthetic for the case. The potential effects of the drug on the breast milk production. Some drugs are thought to anecdotally lower breast milk productions, like cold medications, diphenhydramine, ephedrine, pseudoephedrine. The amount of drug excreted into breast milk and the extent of oral absorption by the breastfeeding infant. We'll discuss that on the next slide. Potential adverse effects on the breastfeeding infant. Narcotics can make the baby and mom sleepy, so we advise that breastfeeding patients on narcotics have someone else to help care for the child and be able to monitor the child for sleepiness. The age of the infant is also an important factor in the decision-making process, as I mentioned earlier, because adverse events associated with drug exposure via lactation most often occur in those younger than 2 months and very rarely over 6 months. Proportion of feedings that are breast milk. The more breast milk a child takes, the more volume of whatever anesthetic or drugs that got into the breast milk will be consumed. So I tend to be more conservative with a mother who has an exclusively breastfed 4-month-old than a 4-month-old who receives a mix of formula and breast milk. Provide information regarding perioperative lactation so that the patient can make decisions regarding lactation management. So that's where educating the patient comes in and teaching her about available resources, both online and in the community. Collaboration with healthcare team and pediatrician. So we defer to the pediatrician as they're the direct healthcare provider for the child. Unfortunately, they're not always aware of the safety of breastfeeding after surgery and anesthesia. So all these factors affect if and how much of a drug may get excreted into the breast milk and or how much the infant may get into his or her system. So these factors will give you the probability or likelihood of a drug getting from mom into the infant and causing possible adverse effects. So most of these factors are directly correlated, except for the two that I labeled as indirect correlation. So first, and usually the most important factor, is maternal blood level. Remember those semi-permeable membrane problems from high school chemistry, how things can equilibrate and move by passive diffusion? As the maternal drug level drops, usually the level of the drug in the breast milk drops too. The more lipid soluble the medication is, the more likely it is to be present in the breast milk. The more protein bound a drug is, the less likely it is to be present in the breast milk. The more oral bioavailability, this is for PO drugs that mom takes, the higher the drug level and likelihood of getting into the breast milk. The longer the plasma half-life in mom, the longer it will last in mom's blood level and be present in the breast milk. The larger the molecular weight, the less likely it will make it into the breast milk. So this, for example, is one of the reasons why Sugamidex is thought to not penetrate the breast milk compartment. It's a very large molecule. So let's say baby ingests the breast milk and there's some drug in there. Most drugs have poor oral bioavailability and are destroyed by the baby's acidic stomach. And some drugs are poorly absorbed when ingested with breast milk. So even though baby got some propofol via the breast milk, very little will pass through the baby's gut to affect him or her. Also, drugs may get sequestered by the infant's liver rather than reaching the plasma. And not unexpected, drugs with longer half-lives in an infant can accumulate, including active metabolites that have longer half-lives. But the maternal blood level isn't always the most important determining factor for some drugs. Sometimes drugs become ion trapped in the breast milk. This is due to the lower pH of human breast milk. The drug becomes ion trapped and cannot enter back into the maternal circulation. Drugs with a higher pKa, like those weekly basic drugs with a pK more than 7.2, are more likely to have a higher breast milk to plasma ratio. Trapping can also occur due to specialized transport systems that pump substances like iodine into breast milk. So this may cause the drug to concentrate in higher breast milk to plasma ratios. And because of this, drugs with iodine like betadine should be avoided, even if they're just being applied to mom's skin. If a lactating patient receives a drug that is incompatible with breastfeeding, she should wait about 5 half-lives before using her breast milk for her child. So here are some resources available to lactating patients that we typically teach the patient about preoperatively. I'll discuss my favorites later, but I'll point out that my favorites here are LactMed and the Infant Risk Hotline. Both are free. So we've received the alert and the patient is coming in, and we've called and hopefully spoken to her now, and we document our conversation, and we usually email our surgical team. We also send them a little cheat sheet that summarizes our medication recommendations and has a list of resources if they have any questions about compatibility of postoperative medications while the patient is breastfeeding. So this is just an FYI slide in case you're ever asked. X-rays, CT scans, MRIs all do not require breastfeeding interruption. PET scans, though, may require interruption. So we still struggle with this, even at our institution. As recently as a few weeks ago, I spoke with a patient who was told she had a pump and discard for a day after her MRI with contrast. So This was actually really hard for her. She had a 1-year-old who didn't want to take a bottle. Mom's been home working from home and only wants mom because mom is around. So there's no reason to make mom pump and discard breast milk after x-rays, CAT scans, and MRIs. So this is an order set that we've been working on for quite some time, and we've been trying to do this for pre-surgical testing, that when they get someone who's breastfeeding, they fill out this order set that we actually modeled on our obstructive sleep apnea stop bang questionnaire. And I'm going to be honest, this is something that has been worked on for 5+ years. It's a work in progress. So we've discussed our preoperative pre-surgical workflow. We're going to move on to our preoperative holding area workflow on the day of the procedure. So the anesthesiologist caring for the patient does their usual pre-anesthesia evaluation and provides additional patient education regarding lactation and medications that will be used in the perioperative period. So this may be the first time the patient gets a chance to talk to an anesthesiologist about breastfeeding if we're unable to reach her preoperatively or if she was not flagged initially. We typically advise that the patient breastfeeds or pumps immediately prior to undergoing anesthesia. We want to reduce the risk of plug ducts and mastitis, because usually sleepy moms in the PACU do not want to pump right away. So we're just trying to buy her some extra time by having her empty pre-procedure. The only exception may be like a mom who, say, only nurses at night, may not need to pump before the procedure. The pre-surgical nurses facilitate inspection of the patient's personal breast pump by biomedical engineering and arranges for breast milk storage as needed. So this is usually more for inpatients than outpatients. At our main hospital in Josie Robertson Surgical Center, which is a one-night stay facility, we have locked refrigerators available specifically for breast milk storage with centrally monitored temperature and a hospital-wide set of policies and procedures on how to label and store the breast milk. You're not supposed to just stick the patient's breast milk in the staff break room refrigerator. At my outpatient surgical center, we do not have these type of refrigerators. For those of you who are not aware of common breast milk storage guidelines, according to the CDC, breast milk at typical room temperature is okay up to 4 hours, and in an insulated cooler with ice packs up to 24 hours. So if the patient brings her cooler with ice packs to the outpatient center and wants to bring the breast milk home, then a refrigerator really isn't necessary. So let's discuss our intraoperative management. The anesthesia and surgical teams discuss perioperative analgesia, including non-narcotic analgesic use, an indication for post-operative breastfeeding interruption. If we hadn't already, we'd share our cheat sheet with the surgical team. Intraoperative nursing staff are asked to use chlorhexidine over betadine whenever possible, and to avoid applying surgical skin preparation to the breast. If possible, we give additional IV fluids to account for the increased fluid requirements of lactation. And whenever possible, regional anesthesia would be preferred in order to minimize IV medication use. Okay, let's talk about our intraoperative medication. So I spread these out over 2 slides. And what we did is we researched the medications by looking at our evidence-based resources. So this included Lactamed database, inhalesmeds.com, and at times we've had to call the infant risk hotline, mostly to inquire about some of the newer medications before they got included in the other databases. So for agents that do not require breastfeeding interruption, breastfeeding may be resumed once the mother has achieved an awake, stable, alert state for a healthy, full-term non-neonate. So with mom, I usually make a little joke out of it and say that after typical anesthetic, the breast milk is okay to use once you're awake and alert enough to hold the baby to breastfeed without dropping him or her. We do defer to the pediatrician, and again, always advise the patient to consult the pediatrician, especially if the baby is preterm, neonate, or has medical conditions. So there are very few medications that require pumping and discarding of breast milk in the perioperative period. The STAR medications here, like ketamine and dexmedetomidine, are likely compatible with breastfeeding, especially in the low doses used in the outpatient setting. Propofol, midazolam, the typical IV narcotics, acetaminophen, ketorolac, the inhalational agents, local anesthetics, including Exparel, All are compatible with breastfeeding once mom is awake and alert, especially in the doses we're using for our outpatient surgeries. Repeated and high doses of narcotics like hydromorphone may lead to respiratory issues, so that is why I will say that my recommendations are based on the typical doses you see in the outpatient surgical setting. And avoid meperidine, as it may interfere with nursing and can cause infant sedation. We have better narcotics anyways. I listed the PO narcotics here in this chart, but we'll discuss this a little bit later in the postoperative section of this talk. Okay, so the medications you see on this slide, like muscle relaxants and the reversal agents, antiemetics, all are compatible with breastfeeding once mom is awake and alert. This scopolamine patch and prochlorperazine can both be used as antiemetics. They're not our first choices, and you should really only be used in the immediate short-term perioperative period. I double starred ephedrine and phenylephrine because, as I mentioned earlier, they are thought to reduce breast milk production. So, you know, repeated doses are thought to be more problematic. But if a patient needs pressors, you give it. But, you know, maybe you can give a little extra fluid too. The intraoperative dyes like isosulfan blue, methylene blue, and nuclear medicine mapping agent technetium require pumping and discarding. So our patients that have lymph node mapping typically get both isosulfan blue and technetium. So we educate our patients they do have to pump and discard them for 48 hours. Indocyanine green has such a short half-life, it's a non-issue. Okay, let's talk about the PACU. All right, so we encourage the patient to continue her typical breastfeeding or pumping routine as much as she can. So if she's due to pump and PACU, hopefully a nurse will help her because she may still be sleepy and need some help positioning herself. Depending on how often mom pumps or breastfeeds, this may or may not happen in your outpatient center. So at my outpatient site, we do not have hospital grade breast pumps. We do have them though at our main hospital and main ambulatory surgical center, Josie Robertson. The patient will bring home breast milk for use or storage when appropriate and feasible. So when would she possibly have to just pump and discard her breast milk that she's pumped in the PACU? So a very sleepy mom, especially one of a newborn, or again, a mom who may have received a drug that is incompatible with lactation like isosulfan blue, she should discard her breast milk. And lactation program members are available for questions or concerns in the perioperative period. So let's talk about post-operative oral analgesics. So you should avoid coating because of the risk to the baby if mom ends up being a rapid metabolizer and floods the breast milk with narcotic. Hydrocodone and oxycodone are safe up to 30 milligrams per day. Another caregiver should be available to help with the baby and monitor him or her while the lactating mom is taking these types of medications. Other typical post-operative non-narcotic medications, Motrin, Tylenol, diclofenac, are all compatible with breastfeeding. Just please do not avoid pain medications because the patient is breastfeeding, because pain can interfere with breastfeeding and pumping. Okay, so our next few slides are from the ASA. Is the ASA interested in anesthesia and lactation? I'm going to say yes. Some of you may all remember this. It was the cover of Anesthesiology in 2017. And this graphic is also from Anesthesiology in 2017. This is great to keep on hand regarding the compatibility of common anesthesia medications. This is the ASA statement on the resumption of breastfeeding after surgery approved in October of 2019. Essentially, the publication discusses a lot of what we've discussed, such as the compatibility of lactation with surgery, the use of multimodal pain medications, and importance of treating pain in lactating women. Again, don't be scared to treat pain because it can interfere with breastfeeding. Okay, so here are some breastfeeding resources available to healthcare providers. So my favorite, again, LactMed database, Infant Risk Hotline, and MedsMilk, which has now been renamed HalesMeds.com. So HalesMeds.com requires a paid subscription. Luckily, our hospital has one. They also have a phone app that you can buy. LactMed and Infant Risk Hotline are free and available to everyone, and LactMed has their own free phone app that you can download. So I thought it would be useful just to quickly show you what to expect when you use some of these resources. So what I usually do is I Google LactMed and follow the link to the web page. Again, it's a free database of drugs through the National Library of Medicine. I picked out ondansetron here. This is what you'll see, and the phone app pretty much looks the same. All right, so this is halesmeds.com. Dr. Hale is an expert in medication and lactation. He authored Medications in Mother's Milk. He runs the infant risk hotline in halesmeds.com, which is a subscription service. So I pulled up ondansetron here at halesmeds.com. You can see a lot of what I've discussed earlier. It includes a lot about the drug characteristics. Sometimes it does have a couple blank spots next to the characteristics, though. A couple of things that you probably can guess, but T1/2 is the half-life, MP is the breast milk to plasma ratio, Tmax is the time until maximum maternal plasma level, PB is protein binding, MW molecular weight, oral means oral bioavailability, VD is the volume of distribution, PK is the acid dissociation constant to let you know if there's a risk of ion trapping. RID is a relative infant dose. It is the infant's dose via milk divided by the mother's dose. So it's an indicator of relative neonatal exposure of a drug. So the usual cutoff is under 10%, but please note that not all authors calculate RID the same way. So it's not a perfect indicator. So here you'll notice that Dr. Hale categorized ondansetron as an L2 if you look at the top. And that is part of a categorization system where how he says how safe a drug is. And I'll show you a little more on the next slide. This is also from halesmeds.com. And he basically categorizes everything from L1 to L5. L1 is as safe as you can be. L5 is the least safe. Most anesthetic drugs fall between the L1 and the L3. I try to avoid drugs that are L4. Now you have to weigh the risks versus benefits, and L5 is truly hazardous and is incompatible with breastfeeding. So I really think he did a nice job defining these compatibility categories, but they're only available in his book or on his website, halesmeds.com, not on LactMed. Okay, so this is the webpage for the infant risk hotline, and they're a hotline that you can call if you have any questions about medications, whether you're a physician or a patient. And this is what we've had to do when we've had new medications that hadn't made it into LactMed or HalesMed's database. Okay. So a couple published resources, 2 articles from 2018 that I've referenced and Dr. Reith and I authored together. And here is the Academy of Breastfeeding Medicine Protocol number 15. It's a valuable reference regarding the safety of perioperative medications. And here is the most recent copy of Hale's Medications in Mother's Milk, which is typically published about every 2 years with updates. But we can't do all that. So I've described an extensive lactation program for my hospital. It took years to develop and continues to evolve. So I've included on this slide some ideas that I think even small outpatient centers can try to do to improve the lactating patient's perioperative experience. So if there's any way to have your pre-surgical clinic or surgeon's office screen and alert you so that an anesthesiologist can call the patient and tell her how to prepare. So many healthcare providers misinform these patients, and these moms are already stressed out. They have to go surgery, and now they have to worry about, will I have enough breast milk? Am I going to be able to feed my child? And what am I going to do? My child doesn't take a bottle. Am I able to even take any pain medication afterwards? So just using that time to call and tell the patient to bring all her supplies and her pump. Let her know what to expect, but sometimes moms just assume that a hospital or a surgical center just have everything she needs ready for her to use. Sharing your knowledge here is helpful because it's not only great to have a supportive anesthesiologist, but having supportive perioperative nurses and surgeons are helpful too. For example, the preoperative nurse can let the patient know that it's almost surgical time so that they can pump. The PACU nurse can also gently remind the patient that it's her time to pump out in recovery. And whenever possible, try to avoid medications incompatible with breastfeeding. And I know it's not always possible, but sometimes there are alternatives, especially if maybe you can do a regional anesthetic. Most importantly, for agents that do not require breastfeeding interruption, which is almost all typical anesthetic medications, breastfeeding may be resumed once the mom has achieved an awake, stable, alert state for a healthy full-term non-neonate. So even with this, we always ask the patient to consult her pediatrician, especially if the baby's preterm and neonate or has medical conditions. But do not automatically just tell mom she must pump and dump for days unless she truly receives a medication that is incompatible with breastfeeding. Okay. All right, so let's change gears a bit and let's talk about that lactating patient that I introduced earlier on. Okay, our first lactating patient we had at our surgical center, the 32-year-old scheduled for a cystoscopy and TURBT. So she was seen in our pre-surgical clinic. She had undergone multiple TURBTs and intravesical immunotherapy. She has a history of mild nausea with anesthesia, and she's allergic to macrobid. So through the review of system screening during the pre-surgical clinic visit, the patient was identified as breastfeeding a 5-week-old healthy infant, triggering an alert to our team. I called the patient preoperatively, and she told me that the baby was born full-term, healthy, requiring no stays in the NICU or special care nursery, and the baby had no current medical issues. I made sure she got our patient education handout during her visit and reinforced that she should bring everything with her, her pump and all her accessories, cooler with ice packs, on the day of the procedure. I asked her to also speak to her pediatrician about breastfeeding after surgery, especially because the baby was young. She told me that she breastfeeds or pumps every 3 to 4 hours, and the baby does take a bottle, and at night sometimes is given formula. I advised her to pump or breastfeed right before surgery and try to maintain her schedule as best she can on her day of surgery. Since she had a baby so young, I thought it would be good for her to go first, and I was able to move her up in the schedule to the first slot. I told her to try to stay well hydrated the day before, and I told her my usual: once you are alert and awake enough to breastfeed your baby without dropping her, you have enough drug out of your system that the breast milk is safe to use. I said if she is sleepy after surgery and pumps, that the breast milk should be discarded, especially since the baby is so young. When a lactating patient has an older child, sometimes I'll tell them about the little diluting milk trick where you take the pumped milk from the post-op period and mix it with either formula or other breast milk that had already been stored to dilute out minute amounts of drug that she may have in the breast milk. But this baby was really young, and I wasn't even going to suggest that. I also referred her to the patient education handout where our references are listed, and I told her about LactMed and infant risk if she has any medication questions. So our typical cystoscopies and TURBTs, again, general anesthesia with an LMA. Sometimes the surgeon wants a little bit of paralysis during the procedure, which is why we typically do it this way. We also have found that giving the patients belladonna and opium suppositories while they're asleep is usually helpful, and then we typically give them Perioperative or even oxybutynin in the PACU as needed. So we don't typically have lactating patients come in for urologic procedures, especially TURBTs, as the average age of bladder cancer is closer to 70s and not 30s. So I wasn't really sure about some of these medications, the belladonna and opium suppositories and the Perioperative and oxybutynin. So first, what I did is I looked up all 3 medications, and I couldn't find belladonna and opium suppositories on LactMed or on halesmeds.com. So I actually ended up calling Infant Risk, who told me to avoid the B&O because they would advise 12 hours of pumping and discarding after its use. And this patient, a 5-week-old, mainly takes breast milk, so I didn't want to use that drug. So instead of giving the B&O, we were just going to stick to the oxybutynin and the Perioperative because short use of the medications is compatible with breastfeeding. So the patient pumped prior to surgery in the preoperative area, and she had a general anesthetic with the LMA and desflurane, and we gave her 200 of propofol, 200 of fentanyl. She got a small dose, 20 of rock, when paralysis was requested by the surgeon, and we reversed that with 3 milligrams of neostigmine and 0.4 of glycopyrrolate. The additional medications she received included a gram of Tylenol, 4 milligrams of dexamethasone, 4 milligrams of ondansetron. She did get a little bit of phenylephrine, ephedrine, and she got Ansap. And she ended up getting about 1.5 liters of lactated Ringer. Okay, so how did she do? She did really well. When the patient was awake and alert in the PACU, she pumped, and she had the cooler to bring home her breast milk from the preoperative and postoperative areas. And the baby was fine, and she went back to her usual breastfeeding schedule and required only some oral acetaminophen after she got home. And I have to say, we had a very prepared and very satisfied patient. So that I think covers almost everything you need to know. And my references are on these two slides. Just want to give a little plug for MSK. We have a virtual conference coming up in December. And I just want to thank you so much for joining and take any questions that you guys might have.
Thank you, Dr. Barnett, for a very informative presentation. We have a bit of time for questions. We received some great questions. Here's one from Philip Mosca. He said, you mentioned chlorhexidine. What about Chloroprep? I just looked up Chloroprep. It's a mixture of chlorhexidine gluconate and 70% isopropyl alcohol.
You know, I'm going to assume that it should be okay because I have not heard of isopropyl alcohol being an issue, but let's see if it's in LactMed right now. If you give me one sec, I'm going to Google it and see if we can find it online.
And I would just reiterate that we do ask the nurses in the operating room and also in the recovery room to make sure that everything is wiped off. And we also try to mention it to our moms just to make sure, that orange tint is wiped off before they resume nursing.
Yeah, I don't isopropyl alcohol. I'm trying to look and see if I see it on here. I don't see it listed in LactMed. I'm going to say I assume it's fine because that's probably what we use. But
And I think it's pretty much equivalent to Purell, I would say. So I think,
yeah, I think it should be fine. Yeah, especially for just the skin. Yeah, I don't think it's on here either. Yeah,
Purell is 70% ethyl alcohol.
yeah, I would think it would be okay. Better than betadine because, like I said before, the iodine is actively transported and gets trapped in the breast milk. So, sometimes you may not have a choice because, that's what you have available, but I think it's always best to try to avoid the betadine whenever possible.
Yeah. Catherine Tobin asked, what do you think about scopolamine patches in ambulatory surgery for a woman who has severe PONV but is also breastfeeding?
So from what I've read on the scope patches, that it's okay in the short term. I would try to, if possible, avoid it. I think we have better things. At our institution, we use a Prepitant a lot for patients that have very high risk. We have like a scoring system, and if they score 4, we give them the a Prepitant preoperatively, and then we also typically give them dexamethasone 4 milligrams and then the Zofran 4 milligrams intraoperatively off the bat. So we haven't actually been using scopolamine where I'm at. I think, again, like you could use it in the short term, but it's not something you want to keep on a patient for 3 days. If you do put it on a patient, you're going to want to tell her to take it off, pretty quickly.
And also, just to add with scopolamine, as you always tell them, if you don't touch it with your hands and then touch your mouth or your eyes, you would also want to emphasize, wash your hands if you need to pull it off, because if you're going to be in contact with a baby, you don't want them to ingest any of it or get it in their eyes either.
Absolutely. Absolutely.
Dave Seipel asked, are you allowing nursing infants to accompany mothers to your center in spite of COVID recommendations? That's an excellent question.
So I know pre-COVID we were allowed to, though sometimes there was some resistance there. But I know, like at my surgical center before all this COVID stuff, kids were coming in, nursing or not. We allowed people bring in, more, we allow people to bring their kids. So if someone wanted to breastfeed their child, it would be no problem. The issue now is post-COVID. They are now starting to allow people to bring one care partner. It's very strict. They have to fill out like a questionnaire, and there's a screening form, and they get their temperature checked. I don't know that they'd be allowed to bring their infant in because they're only allowed one person. So baby would make second person, and then they're not even allowed as of right now to even wait in the waiting room. They actually have to leave when the patient's having surgery. So, I think that when this whole COVID thing is over, if it's possible to have the baby come in, I think it's great. I think it's awesome. You might get some resistance from other people at your institution, but I think it's even better than a pump. But I probably would wait quite a bit after COVID. You also don't know exactly with there's so many unknowns with it. I don't even know if you want to risk baby coming in and getting exposed, even though I know we're all taking the precautions, but you just never know.
Good point. What do you do, Kara, when a patient's pediatrician recommends that a lactating mother pump and discard after anesthesia, and based on the evidence, the pediatrician is clearly wrong?
Yeah, so that's a tough one. So what I've done in the past is I've actually, there are a few times I've emailed patients who had talked to their pediatrician before I got to them, and they were told by their pediatrician to pump and discard. I actually would email, I think I emailed them the ABM protocol, maybe one of our articles, and said, here, show this to your pediatrician, not only to, again, the patient will feel better by having the evidence-based material in front of them, but also to teach a pediatrician that they're wrong, which can happen quite a bit. And maybe they can learn from it and realize they shouldn't just be telling everyone to do it right away. But again, this is the baby's doctor. We can't sit there and say, no, they're wrong, you must not listen to them. But I think it's a great time to also educate both the patient and the pediatrician at both at the same time.
Kara, can you discuss the challenges that you faced when caring for these patients, in addition to what you talked about in your talk?
So I think one of the biggest issues we've had is the conflicting information. So again, one of the recent patients we had, I told her again, the usual, once you're awake and alert enough, your milk is safe to use. She was an inpatient, and one of our nurses on our task force went to go upstairs and check on her, and heard that I think the PA had told her she had a pump and dump for an extended period of time. And I was like, no. And she actually called me while she was with the patient, and I comforted the patient, said, no, you're fine, et cetera. So I think really the conflicting information is the biggest issue. And no matter how much we educate and have all these policies and procedures and everything else at our institution, there is always a couple people that we have to, do damage control. So really, I think the biggest issue is just the conflicting things that all the patients are being told.
Great. Kara, also wondering, how have you educated your staff at MSK?
So we've had quite a few presentations specifically for the anesthesia department, and every once in a while we send an email out reminding everyone. We have a area of our website where we can share like articles and other types of information. So every once in a while when information gets updated, or we make, or there's a new good article or whatever it may be, I go on there and I add it to our website so it's available to everyone. And also, like, for example, when we had that patient come in at my regional site for the first time that was breastfeeding, is actually right before we did our Academy of Breastfeeding meeting, Elizabeth. So what I ended up doing was taking our presentation and actually did several in-services for all the staff to let them know what to do and what to expect. I also sent out information to all. We have a CRNA attending model where I'm at. So I sent like kind of our cheat sheets and our information to my staff at our site. And also, I think that we have a very good relationship with the pre-surgical nurse practitioners. So we've educated them and they know how to contact us and they know where the education is. And we also have formed a lot of good relationships with some of the office practice nurses, especially for head and neck, since we have so many patients getting thyroidectomies that are lactating. And so we've made a lot of these connections and are able to, educate everyone. And, the surgeons, even though, a couple of our surgeons, I swear, get almost all of the patients that are lactating, we still send them the cheat sheet. We still send them the same kind of thing, because we want to make sure that, everyone remembers how safe it is, because we want to keep telling our patients the same thing.
That's great. Thanks so much, Dr. Barnett, and thank you all for participating in this webinar. The recording of today's webinar will be posted on SAMBA's website in the near future for all SAMBA members to view. We hope you will join us for next month's webinar, Thursday, August 27th, as we hear an update in pediatric ambulatory anesthesia from Dr. Michelle Harvey. Registration is open now. Thank you and have a great evening.